Hey, thumbs up. You can see my slides. Excellent. Thank you. Thanks a lot for inviting me for this talk. This is should be pretty fun conversation. So when we were approached to talk about AI, we were kind of given some direction on exploring AI in the sense of clinical and population veterinary medicine, and how we might be able to, or what we're seeing in terms of harnessing this technology in sort of the clinical domain and the real life domain. So we're not going to focus a lot of our conversation on sort of the background of artificial intelligence, like what is a large language model and that kind of thing, but more so just briefly introduce some of the innovations that we're seeing in the marketplace, and also in the research setting, very briefly. And so my task is to share some of that from the clinical domain. This is a little bit about me and the stuff that we do in our lab. We do a lot of fun things with machine learning and computer vision and medical image analysis. And one of the things that kind of tie things together is this theme of One Health, where we're using artificial intelligence in a variety of ways. And I'm sure Bernardo will speak a lot about this connection, particularly with population medicine. So if you were to look at the trend of artificial intelligence and use a metric of publications that have occurred over the last several years, you would see something like this, a logarithmic trend where you see a dramatic increase in the number of publications in artificial intelligence in veterinary medicine. So this is a search on veterinary medicine and artificial intelligence. You can see that line is increasing with time. And noted also here are some important historical landmarks, things like ImageNet and AlexNet, and then also the OpenAI GPT-3 model that came out in early 2020. And so this just kind of emphasizes the fact that we're seeing a lot of this, not just only in the research domain, but in our everyday lives. What kind of innovations are we seeing in clinical veterinary medicine? Well, I want to take a quick step back and talk about how do you see these innovations, and what are the things that drive how you see these innovations, AI innovations, in any kind of community. And I like to think of these sort of four quadrants when it comes to data and information. You can be in a space where there's very poor data, but it can be very information rich, or you can be in a space which is information poor, but and also data poor. And our goal here is to be in sort of that bottom right quadrant where you have rich data and you have rich information. And what are the things that kind of drive going from one space to another? Now, veterinary medicine tends to be kind of a very poor data environment in some ways, but we also have a lot of information which is kind of trapped into the experts of domain expertise, of domain experts. So how do we go from going into that bottom quadrant? Well, the first way to go from a data poor environment, an information poor environment, to a data rich environment, at the very least, is to digitalize the process. And what I mean by this is taking things like paper records, taking things like biomarker data, and having it in a digital form, being able to access that information digitally. Once we do that, once we can digitalize this information, we can then start using that data for clever things like artificial intelligence. And this is where the sort of the automation and AI step comes in. So once you have sort of a data-rich environment, you can then extract information from it. And so this is kind of the goal. And so everybody, wherever you are, whether you're in a clinic or whether you're working in a research setting, have to think about where you sit within sort of this quadrant and what kinds of things you can do to go from one quadrant to another with the goal of going in this bottom right quadrant. And so what we're arguing here is that in order to go from this data-rich, information poor to a data-rich, information-rich environment, we can leverage artificial intelligence. And this is largely evidenced in the FDA-cleared products that you would see on the marketplace today. This is a snapshot in October 29th that registers the number of products, human products, that are FDA-cleared. And if you look at the top of the list, you'll find things like radiology and cardiovascular, the field of cardiovascular studies and neurology is sort of at the top, and they tend to be data-rich environments, and it's easy to leverage artificial intelligence in those spaces. And if you look further down the list, you'll see that some of the other sort of unique specialties don't have as many FDA-cleared products, and one has to ask, well, how much of that data is actually in a space where how much of that data is it a poor data environment, and how might you get to a data-rich environment? Now, I'll give some examples of where we're seeing some of the innovations in veterinary medicine. And the biggest one that everyone probably is talking about are these large language models and how to deploy them in a clinic. And again, what is the data-rich space here? Well, it's effectively the internet. Anything that is freely available or accessible online is data. And so people are leveraging this information, this large data-rich space, to develop an AI model. And here are some of the commercial large language models that we're seeing in the marketplace today. Many of these are focused on taking some kind of text and then transforming it in some way, like summarizing some information or suggesting a diagnosis, et cetera. And so effectively, people can take the data that exists out in the internet in all sorts of public repositories, train an algorithm so that it can customize and generate an output which makes sense to us, such as developing a care plan or providing a structured report. And so again, the workflow here is that the data is going to be that it consists of websites and Wikipedia entries and licensed content and images and video in the latest version of ChatGPT 4.0, then gets ingested into a model, an intelligent agent, which then spits out this information, which is effectively binary information, I might add, but it's structured in a way that makes sense to us as humans. And this is effectively what a large language model is. And so an example of this currently in Cornell here is testing out a VetTriage system. So this is a large language model that can do a variety of things. It can record, process, generate information. You can record consultations using an audio. You can process a session and generate notes. And so here are some of the features that these large language models can undertake, summarizing patient history, generate SOAP notes, et cetera. And you can even put it on your phone. So these are the kinds of some of the innovations that we're seeing today in the marketplace. Another major innovation, again, because of the fact that we're in a data-rich digital imaging space, is in medical image analysis. And so you're seeing a variety of companies that are able to do things like provide diagnostics on medical images. So X-ray images, it could process that and give you suggestions as to what that disease might be. So here's a video of what that workflow might look like for one of those products. This is Radimol. So I just went on the website. You can click on a patient and it can give you a suggested a diagnostic. And if you look here, you can also see heat maps. So it alerts the reader as to what features that are in the image that are driving that diagnostic of cardiomegaly in this instance. This is a couple of slides courtesy Dr. Beck Thompson, where you can do, for example, monitor or track patient's history. So in this case, you have this history of Frankie's journey. You have this initial assessment. You have this image that you would upload, and it provides a variety of possible diagnostics. Gives you, again, the heat maps so that you can make a discrimination or see if it's making sense to the reader. Are these features that are in the image, do they make sense as far as the AI is concerned? And then generate things like a structured report, which can dramatically improve your workflow and efficiency. Another example is what happens if you have multiple or different kinds of data types. So this might be a space where you might have heavily annotated digital images, and you might have a patient or health information system with things like blood chemistry data. And say our use case here is predicting IBD from lymphoma. So this is a study that we've been doing for a long time, where we take images of cats and we extract features from ultrasound images, And then we merge those with blood serum chemistry biomarkers, and we see if we can predict whether this patient has IBD or lymphoma. And so here are a variety of models that one can generate. We can make a simple model that says, is something normal or abnormal about this patient? We can make a model that says, should you do a biopsy or should you not do a biopsy? Or we could develop a more accurate model, or a more precise model, I should say, that discriminates IBD from lymphoma, or if it's healthy, or if it's some other kind of diagnostic. And when we train our models, we can get accuracies that are shown like this. So you can see that the accuracy is very high for very simple tasks like normal versus abnormal, but it starts to break down as you start to get more, you start to ask more, we try to get a more precise diagnosis. And the funny thing about this study was that when we started to look at why our results weren't looking so great, it got us back to the pathology data. and so we started asking the question, well, can we review some of that pathology data? Can we develop a machine learning model or a computer vision model to help improve the diagnostics? Because if you look at one slide, one pathologist might say it's IBD, and then someone might say another slide looks like lymphoma. But then if you do a study, an intra-observer, intra-variability server study, you might get some conflicting data. And so our solution here was, let's try to throw some semi-supervised machine learning at this problem, where we take some existing human AI models that are specifically designed for digital pathology analysis, and see if we can adopt that to help resolve this problem. And so some of our findings from our team here have been pretty impressive. So here's a slide. We have 66 data sets for one case and 83 for lymphoma. These are stained images. And we were able to achieve a very high accuracy by training an AI algorithm to detect or distinguish between IBD and lymphoma cases, in this case, with an accuracy of about 92%. So we're pretty pleased with the model's performance so far. We can also generate things like heat maps here, which help, again, show or illustrate, point the reader to where the AI is making that decision. What are the features inside this image that are driving that decision? And which can be quite helpful. But one of the things that I'd like to describe here is that these are all really wonderful. I talked a little bit about some of these clinical applications, and then I also talked about some of these research applications. And there's a bit of a disconnect between the two. And this is a quote from Karandeep Singh, who's the chief AI health officer in California, an institute there, who's come up with this phrase, which I really love, and that is research models aren't often implemented, and implemented models aren't researched. And so here in the research setting, we can develop hundreds and hundreds of models, but very rarely do you see them actually deployed in a clinical environment. And rather, those that are actually embedded into clinical environments, maybe we don't do enough research in those environments to evaluate efficacy. So where do we start with even doing something like this? Well, we do have a path, and we can use standardized frameworks like the Equator Network, which is this idea of enhancing quality and transparency in health research, where this group has effectively come up with a variety of basic things that any study or any adoption of technology or clinical trials should consider. So we can all kind of be on the same playing field when it comes to things like evaluating a technology or reporting a study and so forth. And there's actually been some evolutions of these things to accommodate artificial intelligence. So for example, if we're reporting a clinical trial, what are the things that we ought to consider putting in a publication? Or if we're generating a model to predict something, how should we what kind of guidance should be put in developing that model and sharing information about that model? And similarly, guidelines on clinical trial design when AI is involved, and reporting guidelines when AI is involved. Now, many of these things can, what we would often argue is that open tools can be beneficial in a lot of these cases for research and development. And there's a lot of dimensions to open tool adherence to data care principles, interoperability, innovative data science methods, keeping things user design focused, privacy, security, scalability of your tools, open access licensing. This is a very busy slide, but these are all sort of many dimensions that we ought to consider when we're developing these AI tools. And so many of these things are often neglected, but they can be really valuable in terms of making sure that tools can be broadly used and adopted by different researchers. When it comes to actually clinically adopting these principles or these ideas of AI into clinical practice, we came up with a couple of really important things that teams ought to consider. And we put it into a little figure like this. And so basically, before you actually start anything, you have to really think about learning the basics and collaborating and planning. And then there's a second major phase of integrating that AI into practice. And generally, there's a lot of published work on this actually about what might be sort of the best practices for deploying AI in your clinical environment. And often some of the key things about this sort of deployment or success in deployment is to do things like make sure that people are well trained and understand some basics of AI. Make sure that there's a good multidisciplinary team involved in deploying the AI, making sure you tackle any legality or ethical issues involved. And then after you start deploying it, the concept of managing change and staying relevant becomes very important. That sort of winds down the talk that I had for myself, and I think hopefully this leads a little bit into a segue for my colleague to take the baton and discuss some of the population medicine side of things. So let me stop sharing my screen. There we go. Thanks.
Thank you, Parminder. Let me just get things set. Right. Funny thing, can you I'm not sure if you're still sharing or not because I cannot locate my slides.
No, I'm no longer sharing.
Okay, so that's weird. Right. Well, here's a technological hiccup. Maybe if I try this, and then this. What do you see? You're muted, Parminder.
Yep, you're gone.
Okay, perfect. Thank you. And apologies for this. So with that great prelude and introduction, here we go. So I will very quickly go through a little bit of introduction, and then I'll talk about AI in population health and a little bit of research in the pipeline in my lab, and then I will talk about the often neglected human factor before I finish with a few takeaways. So as already said, I'm a veterinarian, epidemiologist, and modeler. I worked a lot in the whole One Health domain, working with as an epidemiologist with many animal species and humans. And as somebody who is deeply interested in the food health interface, I work on different aspects of the farm to table supply chain. Now, as a modeler, my approach is to fundamentally think about all three pillars of development and deployment of new models or AI technology for health, and that is data, models, and people. And I'll talk more about them as we go along. So when thinking about any model, including AI models, we have to start with thinking, what is the problem? What's the problem that we want to solve? Like, what's the pain point that we are solving? And then I like to think about it as an equation where we think about, for that specific problem, is this going to be a population or individual level model? What kind of model are we going to use? What are the data? Are they publicly available or private? And then also people in terms of both during development and also uptake of those models, are there any incentives or barriers for people to use them? So is AI in animal health markets a good investment? Yes, it is. So already a few years ago, the market size was $1 billion, and this is predicted to go all the way to $4.5 billion in the next 6 years. And the predicted growth rate is about, adjusted for interest, is about 19%. And so if you think about the areas of application, so far, this resonates with what Parmitan shared. Most applications have been in the space of diagnostics, followed by identification, tracking, and monitoring. And in terms of animal type, most have been in production animals, actually, followed by companion animals. And these trends are going to continue, at least they are predicted to do so. Okay, so with this introduction, I'll now go share a few examples selected just purely based on my curiosity and interest. They are not meant to be exhaustive, but just to show what kind of problems, because everything starts with a problem, what kind of problems in the population space people have addressed. So this is probably timely. Researchers in Korea wanted to develop a forecasting tool to predict when and where which farm will be hit with highly pathogenic avian influenza prior to the actual outbreak, so they could prepare for the outbreak or even prevent it. And they used many types of data in this endeavor: environmental, on-farm biosecurity, vehicle movement, meteorological, and also bird surveillance. And they used a supervised machine learning methodology and developed a tool that had quite exciting ability to provide 7-day forecasts. So 7 days before the outbreak, the tool would send alert that this farm is at high risk of imminent outbreak. Closer to home, researchers here in US wanted to quantify weekly risk of porcine epidemic diarrhea virus outbreaks in sow farms. And for this purpose, they use animal movements and environmental risk factors, and also some supervised machine learning algorithms. And then here on the maps, you see in a given week how the predicted risk of outbreak in a given neighborhood, marked with reddish colors, is changing. They had also pretty good sensitivity and specificity for this tool. Another one that is kind of interesting and maybe a little bit acute is nowcasting flea activity. So the fleas are menace, and they're also a source of some infections, some diseases. And so researchers wanted to predict outdoor flea activity levels. They used weather data and then validated their prediction with Google Trends for searches for the term fleas, serving as proxy for flea burden. And so they used kriging methodology, this interpolation methodology, and they developed a real-time daily outdoor flea activity nowcast that looks like this for any given day, and it's accessible freely to anybody. You can access it too. This one is also pretty interesting. So for us to be able to respond or plan for an avian disease outbreak, we need to know where in the US are poultry farms. Now, that kind of information is confidential. So information of farmer location and what production they have is confidential. And so to get around that, researchers first created farm location and agricultural production simulator, FLABS, which creates a synthetic data about where poultry farms likely are. And then in this specific research, on top of that, they cross-reference the simulator prediction with high-resolution imagery to reconstruct spatially accurate national poultry population data set that will be invaluable for in case of any widespread outbreak. This is from Wall Street Journal a few weeks ago, and it said, cow wearables help America's dairy farmers detect bird flu and other illness. Dairy producers are increasingly putting internet-connected collars and ear tags on their cows, helping better track the animal's health and breeding. And truly, this is something that we have seen a lot. So it's not surprised that production animals are the main species where AI technology has been seen in veterinary medicine, and these tools are helping farmers spend more time with animals that actually need their assistance. And so here is the cartoon showing all kinds of sensors that might be used on dairy farms, from accelerometers to pedometers, GPS, pressure platform, environmental sensor, intraruminal sensor, and also heat detector. But it's not only about sensors, so farms are also using video footage. So this is an example where researchers wanted to detect and quantify ear biting, which is an animal welfare concern in commercial pig farming. And so they use videos of pigs and detection algorithms, YOLO 4 and 7, and some tracking algorithms. And they developed a tool that had pretty good prediction accuracy, detection accuracy of this behavior. And then another example, this is actually commercially available, where the type of data being used is sound, where Boehringer Ingelheim developed AI device that listens to and analyzes frequency and intensity of pigs coughing, allowing for the earlier detection of respiratory disease. So it uses the sound. So this is what others have done. Was not meant to be exhaustive list, just to illustrate what kind of problems are being solved in population veterinary medicine. So here are a few examples from my own lab. So a big part of our work is on antimicrobial use in livestock to provide farmers with actionable insights on how to improve animal health and welfare, also how to improve their business, and at the same time providing antimicrobial stewardship solutions in the fight against antimicrobial resistance. And so in this project, we developed AUDIO, which stands for Antibiotic Use in Dairy Investigated Online, which is an online platform where farmer can upload all the information, farm information about antimicrobial treatments with 3 easy click of a button, and they get an interface that looks like this on the right side. I'm not sure if you can see my mouse, but basically, the farmer can subset their antimicrobial use based on animal category, the diagnosis, the antimicrobial class. They can see individual treatments, and they can also see estimates of indicators of antimicrobial use, actually 15 of them, and each one providing slightly different insights to them, based on which they can plan further animal health and welfare, or just business management. And so the next part in this research will be to create a composite indicator of those 15 so that it's easier for farmer to take that information up and use. Now, when I said that use of AUDIO requires just 3 easy clicks on a button, that's actually not true right now, at least, because to prepare data for upload, requires many hours of work, which actually our student did catching COBOL. And so for this to be truly accessible to farmers, we need to standardize and automate data acquisition. And this is what we are doing now. We are leveraging large language models to transform raw digital treatment records into standardized format that is suitable for AUDIO and to reduce manual effort. This research also involves interviews with farmers and veterinarians to make sure that we are addressing exactly what their problems are, what their pain points are, and to improve the probability of this kind of technology to be used. And also, we want to make sure that farmers can not just learn from their own records, but also across in a private manner. So this project will also involve development of algorithms for privatized data sharing. Another large area of research in our lab is on more efficient detection of pathogens in different spaces, complex spaces. And so you can imagine like a surgery room or an examination room where if you put a yellow dot on the places that are concerned for you in terms of the risk to a patient, maybe some nosocomial pathogen, and then lines indicate possible cross-contamination avenues. So if you do this would create a network or probabilistic model of pathogen cross-contamination. Now, we don't study this in healthcare. We actually study this in food production environment where stakes are equally high, as we have to prevent food contamination, as that leads to illnesses and deaths. And we are developing active learning algorithms that are able to learn as search and testing is done. From every next test done, the future selection of sites for tests are being updated. This kind of technology, once developed, could be implemented to different spaces, including healthcare. Another area of research is on modeling of infectious disease spread. So this could be infection spread in any population of animals, also people. And the goal is to create a map, prediction like this, where we have over time, we are predicting how many animals we will have sick, when is the outbreak. And so we use this to forecast infection spread and also to learn about effective interventions. Now, traditionally, this is a really laborious process, and it requires a lot of synthesis of information. We draw a diagram of infection spread, everything we know about this disease, or we wish to know, in something like this, and then we create, we translate diagrams into equations to be able to use those equations in a model. What we want to do now is to, rather than handcrafting those equations, we want to learn equations directly from data through a process, through AI method that's called symbolic regression, which is different from machine learning. It's if you would think about machine learning as experiential learner that learns from seeing a lot of data, symbolic AI mirrors human reasoning through explicit symbols and logic. And so here we are comparing two methodologies. One is genetic programming that pretty much allows evolution of programs or equations over starting from a very wide population of possible equation sets. And then the process may look like this, where as different equation evolves over, or equation set evolve in this search for the best equation set, they are compared with the data, and the equation set that is closest to the data is considered a candidate for the learned equations. So we are comparing this genetic programming approach with equation learning, which starts with the library of terms that are more explainable to us, and that we allow search just based on those terms, and that typically leads to more explainable models, but accuracy is sacrificed. And so what we are doing with these two methodologies, we are testing them on synthetic data that are simulating infection spread with different levels of sparsity, because as we know, especially for infection data are never pretty, they are never complete, there is always something missing, the frequency of data collection is not enough. And so we want to see how these methodologies would work in settings that mimic real data, sparse data setting. And then this project is on literature screening, so all of us have to stay abreast of literature, and for us in academia, this means the gold standard is systematic reviews, where we go through many databases and find thousands of articles, and then we have students dedicated to manually search through those articles to identify those that we want to examine more closely because they are addressing the question that we have. So we wanted to see, can we use AI to make this process more efficient? So we used a data set where we had nearly 4,000 articles already manually screened by students, and about 200 of those were considered relevant. I see, should we be seeing slides? So you cannot see slides anymore?
No,
I can still see them.
I can't.
Oh, so maybe I stop sharing and start sending again? Let's see.
So I'm not sure why I can't see them and others can.
Yeah, I can
Okay,
see the slides.
now I can.
There you are. You're back on. Thanks.
So is it better now? Meg?
Yes.
Yes.
Okay. All right. Well, I hope you guys didn't miss a lot. Okay. So anyway, we wanted to see whether we can do literature screening more efficiently. And so we compared this data set that was already labeled with semi-automated active learning methods. And to illustrate the results, here on the x-axis in this graph, you see proportion of total records. And when you get to 1, that means that you read all 3,000 plus records. And then when you go on the y-axis, if you get to 1, it means that you successfully identified all 214 relevant. And so the purple diagonal line indicates what happens when you do this manually, where you don't have an AI to help you. If you have AI to help you, when you can learn from every article that you reject or that you accept, when you do that, then you actually are able to get to nearly 214 articles identified by only screening 55 or 60% of them. So it represents a great improvement in efficiency. And one other reason why I really like this study to showcase it as an example is because it also allows us to measure and demonstrate the effectiveness of AI, which goes back to what Parminder was saying about the health AI paradox, where we have methods, but we don't research them, which we should, so that users are not left to just trusting that they are doing better. Okay. So with that, I want to spend a few minutes talking about the often neglected human factor. Something that was said in Forbes in an interview with an AI expert recently and resonated with me was the greatest impediment to the successful application and adoption of AI within veterinary medicine, however, is due not to scientific or technical limitations, but to behavioral and human factors. And I couldn't agree with this more. I think just to enhance this human-machine interface, we have to make effort and learn how to communicate in terms that are understandable to humans. And we also have to see and understand the potential impact of AI through human lens. Another issue that is super important is AI literacy of domain experts. So who are domain experts? This is all of you who are listening here, people who are coming from many different domains, from veterinary medicine, epidemiology, biological sciences, and having you in this journey of development of new methodology is super essential. And this is, I agree with the Snyder Jenna, who said, one is likely to spend only 5% of the time training a model and 95% selecting the most appropriate features, which requires biological expertise. So in other words, there is no way to develop meaningful AI without all of your input. And then speaking of that, just want to point out that as we have different types of AI technology, some are descriptive, diagnostic, predictive, prescriptive, there is a lot of space for human input in many of them. And then some of them, there is decision-making, the human input is required for decision-making. And then so therefore, that's why it's important for all of us to understand how this analysis was done, or at least at a bigger level, how what data has been used, all the way to prescriptive, for which we have to be able to trust that the recommendation or decision made by AI is something that can be trusted. So one way to get more data is through data sharing good data. So there was this article several years ago, Sharing is Caring, on data sharing initiatives in healthcare, which talked about barriers and initiatives in healthcare about data sharing. And so this is something we have been very much interested. We are interested in how individual private companies are maybe interested in sharing their data for the benefit of all of us learning together. Like, what are perceptions about data sharing? As a case study, we are not using healthcare, we are using food industry, and we are asking food industry about sharing data relevant to food safety. And so it is for the food industry, and we talked with 27 food industry leaders, but I believe that based on everything we read so far, other studies in other industries, that there is some learning that cuts across different industries and would be applicable also to healthcare. So there are 4 teams that we identified that through this. And then many of the interviews talked about understood benefits if we would share data, how much more we could learn. Technical barriers, and Parminder talk about this, the digitization, still data being on paper, or standardization, lack of it, where we call the same, so we have multiple names for the same thing. Trust barriers were huge, where people brought up loss of business advantage if they share, or even legal liabilities. And then interestingly, several brought up the idea that academia could play a role of an honest broker, an entity that would make sure that the sharing of data across industry members are used and shared fairly. So here are two quotes. Again, these are from food industry, but I believe they cut across, and you can judge for yourself. So one person said, "We even have a challenge within our business around how we standardize data, let alone between different businesses, units, decimal places. I think it's a minefield. And I think if we are going to be sharing data, we got to figure out a clearer nomenclature around some of these things." And another person said, "We shouldn't be sharing data just to share data. If we are sharing data to solve a problem, that's the right context. But then again, it also needs to be protected. There's being transparent through data sharing, and then there is being like naked walking down the street if you expose yourself with data sharing." So I'll finish with very quick takeaways. As I said at the beginning, there are three pillars of development of meaningful AI methodologies, and there are data models and people, and I think there is a lot more work that needs to be done for all of them. And I mentioned already several of those issues in my talk, and here I'll just highlight data need to be representative, and we need public to avoid bias. In data decision, in AI decisions, we need public repositories to help with AI literacy of all users. We need to have developed AI ethics and oversight and monitoring initiatives, and we need initiatives for data governance. And obviously, all models need to be transparent. We need the information need to be accessible to people, how they were developed, how they were structured, and they need to be explainable. So the decision that is recommended or the outcome of an AI is understood. So with that, I will thank my lab and many collaborators that were not listed on the previous slides and sources of funding. And I'll finish on a very happy note. So we have two big things to celebrate. The first one is upcoming symposium on artificial intelligence in veterinary medicine, or SAVI 2.0. This will happen May 16 or 18, when many of these issues that are pertaining to veterinary medicine will be discussed. So we hope you all will come. This is the second time we are organizing this event. The first one was last year, approximately the same time. And many studies that were featured during the symposium were actually published in special issue in American Journal of Veterinary Research just recently, for which we wrote with Casey Kaiser's leadership, we wrote an editorial from Bark to Bites, Artificial Intelligence Transforming Veterinary Medicine, which we hope you will find. So the special issue and editorial, and we hope to see you all at the symposium in May. And with that, well, thank you. I'll stop sharing so I can see you. And yeah, I'll happy to answer questions.
Renata, I have a question, if no one else is first. So obviously the large language models improve access a lot to these AI tools because it allows you to interface directly without having to design it yourself. But Parminder mentioned earlier that a lot of these LLMs are pulling data from the internet. And so obviously there's a lot of information, some of it more true than others. And so in the case of medicine, where obviously the decisions from AI are more consequential, have there been approaches that try and filter that data in some way to the more, quote, reputable sources? Obviously, you might restrict the quantity of data that you have, which is required for these models. But yeah, I was curious if you could talk on what's been attempted in terms of filtering of information, or if that's a viable approach.
Well, that's an interesting question. I will let Parminder talk about filtering. I'm not aware of filtering, although I don't see why it couldn't be done. what we are seeing, what is potentially more critical for medical research is that data are not leaked outside of a group that is doing research. So we might be employing large language models behind a wall so that others cannot access potentially private and quite sensitive information and then learn from it. So that sounds like a bigger concern right now than filtering, but Parminder, do you know anything about it?
Yeah. So, it really comes down to what are the data sources that you're using to ingest into the initial training of the large language model. And so if you were to go on a PubMed website, you would do a random search and you could get, 5 trillion abstracts available for ingesting into a large language model. And many people have done this. So there's a lot of institutions, a lot of people have developed models where they access or they only use data sets from curated sources, right? So they will say, here are 5 different major sites, which they deem to be reputable, and then train the model based on all of the text and information, all the text from those sources. So, this is happening, and there are more and more, like the number of models that are out there is astronomical. Some of these are very specific medical models. So there are a variety.
My picture also? No, not your video.
There are a variety of large language models that are specific to not to veterinary, but to medicine in general. And then there are some others that are, for example, training data to develop chatbots for feline health. And so Cornell has a project where it's called ChatGPT, or CatGPT, I should say, where the data is largely sourced from feline-related information. So it is a little bit of that sort of buyer beware space right now, where you go and seek the large language model and what data is going into it.
Thank you.
Thanks, Parminder, for bringing up CatGPT. I see Dr. Roy Tadhunter is not here today. Usually he's like moth to a flame when he sees AI on something, but he's been instrumental too in putting together a canine version of that for the Rhine Canine Health Center too. I don't know, Parminder, I think you were involved in that as well. The big red.
The big red dog tag. We had a couple of different iterations of the idea.
Is it ready?
Yeah, they can hear you now.
The initial the idea was for us to see if we could train a model using medically tagged information. So if you look at a patient history, for example, and it has a diagnosis code attached to it, you could train a model to predict what the diagnostic code would be if you entered in a variety of symptoms, for example. So that was one idea, and it kind of had a little bit of legs. And then the other idea was to make a more generalized equivalent of a chat bot, but specifically targeting the canine species. And so very similar along the lines of CatGPT, but now sourcing information from for dogs in particular. Now, there are a couple of really great public resources out there, right, that Cornell has actually curated, available publicly online. So there is a lot of this really great data available. There's always some questions about, do we need to tag this data? Like, do you need to have a very unique diagnosis code? What value does that have for, practicing, veterinarians? It really depends on the use case, right? So if you have a general person that's just trying to sort of Google their way to figuring out what's wrong with their dog or cat, then you might not need to have those very specific diagnostic codes. And in fact, it could be kind of dangerous if you provide too much information to a general population. So there has to be sort of, I guess what I'm really getting at is that it is very dependent on the use cases, right? Like what's your use case for that large language model? You have to be very mindful of that and the data that goes into it.
Yeah, I think the one of my concerns actually that came up while Rory was discussing that, especially when it's for veterinary use. And so in one, I know he was trying to get documents from faculty willing to share their PowerPoints, their lectures, that sort of thing. But my concern is with dosages that may be perfectly fine now, but in 5 years, like that might not be the recommendation anymore. So what happens once that stuff's out there? How do you pull it back in? How do you make sure it's still up to date?
Yeah, that's such a great question. And this is a real world problem in human medicine in the sense that people will develop a model. So, for example, there's, now if you go and there are like these sepsis models that are integrated into the health information system. So you put in a bunch of, things, patient information, and it will predict things like, what's the risk of sepsis. And what people are finding is that for some of these models, you work in this environment where you test and train and validate, and then you deploy it. It works, works quite well in the beginning, but then over time, it may not perform very well. And that general idea is called data drift. And so there's a lot of reasons why your model will start to drift out. Some of it is because the data that's going in is changed. And so some of that could be because of improved practices. Because you have this new improved practice, the model doesn't know that you already have these other interventions in place such that the recommendation is no longer needed because it's sort of stale dated learning. And so strategies to ensure that these models are flexible enough to accommodate new information, being able to accommodate different populations, right? You develop a model here at Cornell and then try to deploy at UC Davis, it might look entirely different. All these things have to be sort of really well understood. And so that's an active area of research, and certainly in human medicine. Sorry to barge in, but Rana, I'm sure you probably have some thoughts too.
Well, we've got a question in the chat too, I want to make sure. And I think that's kind of a segue actually to this question. This is from Patrick Carney. How do you prospectively assess refined predictive models? Example, highly pathogenic avian influenza prediction, when the prediction can alter the outcome. For example, the model predicts high risk for the farm locks down and no outbreak occurs. Was that model failure or success?
That's a fantastic question. So there are multiple ways we can go about it. And this is where and how I said earlier that AI literacy for domain experts is super important, because for somebody, a model could be able to accommodate this lockdown if in model features we have something like a control strategy, specific types, or in general control strategies. So if there is something in the data about timing about specific control strategies, that could still be accommodated and predicted in the model. We can also have active learning models that are adapting prediction based on what is seen on the ground right now. So basically, so I think Patrick was asking, what if we have a static model that predicts an outbreak going like this, but then we have an intervention and then we don't see it. So I think it's maybe an unfair question. It's not that the model is a failure. It is that this was the model that had a static prediction. So we need to have different models that are able to adjust prediction based on what we see. So again, this could be as a feature in the model, or it could be active learning model that is able to adapt at every next time point. It takes into account what is happening now, or everything that has happened before. And then maybe it goes back to what we said, both of us said, like every model is developed for a specific purpose. So it would be unfair to expect prediction, a static prediction when things are changing dynamically.
So then Doug Aspros in the chat asks, how is that problem, in parentheses, old data being the basis for an AI assessment, different from human information drift?
In some ways, it really isn't all that different, right? So that is a part of the model no longer being able to predict based on the current circumstances. So the set of variables that are going into managing a patient care today is different than the set of variables that would have happened 5 or 10 years ago. So I would say that it certainly isn't all that different. There are other forms of data drift per se. Some of it can be because of heterogeneity of data sets. So for example, you have say your model uses RNA sequencing, right? And then you built this beautiful model, and now it's doing a wonderful job predicting X, Y, or Z. But then that machine breaks down. Your RNA seq machine breaks down, and you went and bought a different manufacturer, and now that produces a different output. That's a different. That there could be systematic changes in the way that data is generated and then injected or ingested into the AI algorithm, right? So we see this as CT scans. So like, you buy a CT scanner from vendor A, and then you buy a CT scanner from vendor B, and even though they're both kind of giving you CT images, there are variations and differences in the way the CT images perform. And so if you were to, for example, develop an AI model based on radiomic features, that is like extracting digital features from this machine, and then compare it against another machine, your model may not work, right? Or may not work as well. So there's a sort of a technical component to how drifting of your AI algorithms can perform. There's a variety of these possible sources of drifting in AI performance, which in itself is something I'd love to sink our teeth into in a separate session.
Great. Well, thank you so much, Renata and Parminder. A great discussion. Thank you, everyone, for everyone that was here. A really great turnout, great discussion. Want to thank our CBB sponsors again: Triad Foundation, Veritas Veterinary Partners, Zoetis, IDEX, Boehringer Ingelheim, VetTriage, Veterinary Practice Partners, Encore Vet Group, Care Credit, and Purina. I saw several of our industry partners here today, so thanks for being here. Our next Spark Talk, I think, is going to be of great interest to you folks as well, particularly those of you in practice. And it's on the business of mentoring. So when our graduates say the number one thing they're looking for, and it's always been true, at least as long as I've been doing this, is mentorship. What does that look like, and how can we